Okay, so welcome. We've got some of you have joined us tonight on, well, here in Scotland, a very wet and wild evening to talk about measurement for quality improvement and data for improvement. So welcome, really glad to see you all here tonight. The session is being recorded and we will just get started in a couple of seconds. That's great. Can you move the slides on for me? My name is Sarah Lutti. I might have seen some of you before on previous webinars. This is the last in a series. I work as a GP here in Inverclyde, just not far from Glasgow. And I also work for the Safety and Improvement team at NHS Education for Scotland. And my capacity here tonight is for the RCGP doing a project called the QUICK project, which is improvement capacity and knowledge in primary care. And this is the sixth webinar that we've run. So all of these, the series of them will be available on the RCGP YouTube channel, and there's a link to that at the end of the slide deck. And I'm really delighted tonight that we've been joined by a national expert in data, but please don't run away, somebody that's going to translate it for us, and I'm going to let Stuart introduce himself.
Thanks, Sarah. So I'm Stuart Clough. I'm an Associate Director for Continuous Improvement at Lancashire Teaching Hospitals NHS Foundation Trust. I've worked at the organisation now for just over 2 years, but prior to that I've got quite a lot of experience in quality improvement, continuous improvement in healthcare, working across a number of organisations in the northwest of England. In terms of my background, I've had the privilege to be trained by the Institute for Healthcare Improvement. I've undertaken their Improvement Advisor Development training programme, and I'm currently completing the Advanced Process Improvement training with the Virginia Mason Institute. So I'd like to think I'll be able to give you some good advice this evening, and very much like Sarah said, we've got an hour together, so let's make the most of it, and we'll really start to get into some of what data is, but let's not be too afraid as well, because improvement work data is very much our friend. And the final thing to say is some people may be familiar with the Flow Coaching Academy. There's quite a lot of them dotted around across the UK. I'm a faculty member for the central team, hosted by Sheffield Teaching Hospitals NHS Foundation Trust, but I also lead our local Flow Coaching Academy in Lancashire and South Cumbria as well. And my details are just there if anybody has any questions post session, and big advocate of social media, so if you're on there, please connect with me on there as well. And thanks very much for having me this evening. It's a real privilege to be able to speak to you about some of the challenges you might face in data.
That's great. We're really keen. I mean, data's not the easiest subject to teach on a webinar, so we're really keen that this is useful to you. So people that are on the call, you can see that we've got the chat function open, and we've got anything that you're wanting to ask, or when we've talked about something that you don't understand or you want us to go back, please put it in chat. Or if you don't want your name attached to it, if you put it through question and answer, that's anonymous, so we can see those and react to those as we go through. We've also put up a couple of Menti slides, so if you've got your phone and you don't need to download the app or anything, all you have to do is go to menti.com and type in that code. We've got a couple of questions for you on Menti, and the purpose of this is just so that we can set the tone right. So Stuart, if you let me share the screen, I'll put that up and we can see how we're getting on with that. So as I say, the most important thing is that you guys that are giving up your evening get the most out of tonight. So our first question for those of you that have managed to get onto Menti is describe your feelings about data and measurements for improvement. And that's a very, very GP expression, isn't it? Describe your feelings. But once we start getting some answers in the data, they should start appearing on the screen here. Results are hidden. So we should start seeing some results there, because I think data is one of these sorts of subjects that some people love it, don't they? Some people are just very good at looking at graphs and charts and sharing it widely and wisely, and other people are a little bit hesitant. So, I thought the screen going a wee bit strange here. So if you can get onto Menti and the codes at the top there, let's have a wee look at what sorts of things people are feeling. Time consuming is an interesting one. QoF was a lot about data. Do I need to know stats? Oh, well, I'm definitely going to hand that one over to you, Stuart. Do I need to know stats? Intimidating. Yeah, a bit baffled. Baffled is a great word. Yeah. So I think that you're not alone. I think as GPs, you're absolutely not alone in this. And the bigger the word, the more times it's been said. So we're not all saying that it's hard, but I like the fact somebody's put in here valuable. That I think is evidence of doing it right, maybe. Okay, I'm going to move on to the next one for those of you that can. And the next slide is about, tell us about it. Tell us what it is that you're finding hard. So those have said that you're baffled or that you're struggling with it. What sorts of things do you want us to cover this evening, and what sort of things are you finding tricky? And I think I've said that when it's
I think just while they're doing that, Sarah, I think just some reflections on the last slide is that's the typical things that I tend to see. So I'm hoping that the presentation I'm able to give gives a little bit of light into that. And I was really curious when people sort of say they're a bit nervous about it or a little bit scared about it. That's also very typical as well. What I'd like to maybe try and get across this evening is it's not so scary. And the one about the statistics is a lot of time we don't really need to go to that depth. It's about understanding and just doing a bit of analysis at high level. So hopefully we'll cover some of that.
Yeah, so we've got how to plan projects and pick measures. I think that's a really important one, isn't it? What variables to collect stories? That's an interesting one. How do you measure patient experience or patient stories? Yeah. Okay, that gives us some things to have a think about. And as I say, if things occur to you as we're going through this evening, please put it in the chat box and let us know. But I'm going to close that down for just now and let Stuart start his presentation, and we'll just have a wee reference to them as we go through.
Yeah, and again, I'd like to think that some of the things on there about I know some people are interested in the simplicity and things like that. So hopefully that'll come across. Just before I pop my slides up, just want to just sort of reinforce that. A lot of the things you might be thinking of potentially a bit of a simple question or a silly question, please ask it, because I've heard them all, and I think it's really important that you've come to this section with purpose, that you want to learn about. Particularly, we're going to focus on measurement for improvement right here this evening. So it's important that you get what you need from the session as well. So let's see how we get on, and I just encourage you to use the chat function, use the Mentimeter as well, because I think that'll be good. Hopefully we'll have a little bit of time for some discussion as well, with maybe some further burning questions that you may have throughout the presentation. So are we back up at the Mentimeter slide, Sarah?
Yes, that's us. Yep.
Good. Let's see if I can get this moving now. Okay, so we've talked a little bit about this. We won't use this again, so don't worry too much. So we've got a little bit of a sense of how people feel. Some people are apprehensive. Some people are thinking about how we do it. Some people know that it's really important, may not know these sort of things. So we've got. It feels to me like we've got a real balance. We've got some data lovers too, and that's always good. So what can we expect then? So I'm just going to set the scene about measurement for improvement. That's really important because there's different characteristics how we measure things in different situations. That's going to come to light. We're going to think about how and what to measure. We think about understanding those measures. How do we start to do some interrogation of data? So how do we start to understand some of what our data is showing? And then we'll have a bit of a roundup and a bit of a summary. And whilst I talk about interrogating data, the other thing that I'd just like to make a note of this evening is this is a very quick introduction to it. I'm not expecting people to go away and be gurus on it. The data that we'll look at is in statistical process control chart form. I'll try and make it nice and simple, but there are more simplistic tools we can use, like run charts in data. We can talk a little bit about that as well if that's helpful. So the first thing that we need to think about is, so why do we measure performance in healthcare? So what are some of the reasons that we do that? So the first thing is that we almost want to know how we're doing. That's the whole reason. So we're measuring something to understand how we're performing. Have we potentially reached an aim? So I know that some of you may have joined previous webinars, and you've been introduced to a framework called the Model for Improvement. And of that, it asks us three really key questions. It asks us, the first question is, what are we trying to accomplish? So what's the aim? Second thing is, how do we know that change leads to an improvement? Really thinking about the data measurement elements of it. And then thinking about, well, what changes can we make that will lead to that improvement? So we really need to set an aim when we're doing improvement work, because that gives us the ability to say how good we want to be. That's usually as data and by when. So that's key as well. A little bit about variation. So when we do improvement work, we've almost kind of, if people are familiar with Dr. W. Edwards Deming, and Deming thinks about improvement. He's one of the forefathers of quality improvement. And Deming says we need to think about four things, okay? We need to think about the system. So what does the system and the process look like? That's important. What about variation? And variation often leads us to look at things like data. We might look at particular performances of I don't know, as clinics, as capacity. We might think about how other GP practices are performing. So we think about variation, and some of that thinking comes into variation in how we deliver particular processes or particular products, things like that. We also then need to think about people, so making change happen, bringing people with us. That's important for data too, because we need to make data understandable for people. And then we need to have a way of enacting change. And that usually comes through with something like your model for improvement. So having some profound knowledge to be able to do some improvement work. And that's where we really get to the improvement sweet spot. So variation is really important. Similarly, we can use data to understand the effects of our tests. So if we're doing these things called plan, do, study, act cycles, small tests of change, gives us a bit of feedback. We learn from that. That's the whole thing about quality improvement. The science behind it really is the ability to learn. And then maybe we make a change, and maybe it's heading in the right direction. We're really pleased with the improvement work we've done. But then how do we sustain that? And data again comes into its own, because then we can look at data and understand if we're sustaining change over time. And we can maybe put a little bit of assurance in there as well. Are we sustaining the change? If it changes for the worse, can we get it back into our new state of control? So that's just setting the scene in terms of why we measure performance in healthcare. Really important for us to do that. There's a paper that Professor Leif Solberg and others wrote in the 90s, and it's called The Faces of Measurement. And Professor Solberg effectively said there's three different types of characteristics we need to be aware of when we're thinking about data. in this presentation, we're just going to talk about two, which are probably more typical, which is assurance and improvement. There's also a third phase, which is measurement for research as well, which some of you may be familiar with. And that paper is reasonably easy to access if people are interested in it. But the first one we're going to look at is measurement for assurance. So this is having accountability or judgment data. So I've just put playfully up there. I'm guessing a lot of data that you see a lot of the time is like in a traffic light system, red, amber, green. Usually if it's green, that's good, we're performing, we're not too worried about the greens, that's good. If it's amber, we've got one eye on it, but we're doing okay, we can move towards it. And if it's red, of course, what we do with that is we push the panic button and we do some firefighting to just try and bring it back into a state of control that we are expecting to see. So these are things like wait times. So any particular metrics of key performance indicators that you've got to perform in a particular time frame. This is a really good characteristic. So I'm just going to go to my default here. I hope that's okay. But for example, in a secondary care situation for myself, a really classic example of measurement for assurance would be the 4-hour waiting times in an accident and emergency. And it's a straightforward yes or no. Do you meet the 4 hours or not? It's pretty straightforward. Quite standardized, and we use it to adjust as well. We can take the data and we can adjust it. So that's measurement for assurance. And I'm going to make the assumption that that's probably some of the data that you're most familiar with. Is how we perform against the target, yes or no, and we get reams of data and things. So we're not going to focus on that today, but equally what I'm going to just heavily caveat is in this presentation we're talking about measurement for improvement. So what I'm not saying is that there's a right or wrong here. If we're in the space of improvement, we need to look at the characteristics for improvement, not so much the assurance, because the two don't really work together. Okay. So then when we start to think about improvement, well, what are the characteristics here then? So it's I'm going to start at the bottom. It feels very different in some situations because the things that we look at are often smaller scale. We might use less measures. We use a handful of measures. And the key term that we often use in improvement is we just need enough data to understand. We don't need reams of it. We ain't doing a piece of research here. So we're not trying to find out if our hypothesis is proven or not. We're not really that focused on making other discoveries along the way just in case. What we're trying to think about here is how can we focus on making change over time, whatever that looks like, however big, however small. And usually improvement works best when we're thinking on small scale, because we're testing things out. We've got some theories, we've got some ideas, and what we don't know is if they work or not. We'll all this evening have examples where we could talk about where we've had a situation where someone's implementing a change and they've just done it. It feels like the right thing, it feels a good thing to do, we'll implement it. But actually, it doesn't work in how we intend it to work. And similarly, the consequences of getting that wrong can be reasonably significant, really hard to undo. And change is difficult, isn't it? So when we think about making changes, particularly that involves people, people don't like change. And if we get something wrong, because we haven't truly understood the status quo, we haven't thought about what the problem is, we've just thought of a solution, that can be a little bit of a problem. So we want to be in these spaces here. We want to be thinking about small scale, less measures, so we can really take a good look at it. And it will feel a little different. We've just described assurance. I've talked a little bit about research purposes. So it may feel different to what you've even been academically trained into. And that's okay. So then on to the what and the how. So I put together again, it's just a little simplistic schematic, just to try and almost illustrate the ease of collecting measurement where possible. Now, whilst I'm talking about it being really easy, I'm fully aware that it's not, and it can get difficult when we start to think about where we get data from and things like that. We'll have a little discussion about that as well as we move through. But the key premise is that we need to be able to plan what it is that we're trying to measure. So plan the measurement. As I said, small set of measures, things that are the advice that I often give people is think about what's important and not what's just interesting. So think about, if we go back to that improvement framework, what's our aim statement? So hopefully you've thought about some sort of SMART principles. So being specific, measurable, achievable, realistic, and time bound. That sets you up really nicely to start to think through these measures. So, okay, well, the measurement element, I know what it is that I'm trying to do. That's what my key measure is going to be. Maybe there's a little collection of measures. Typically, I would, if I were working with you, I'd maybe say, let's aim for somewhere between 5 and 8 measures for a project, no more, because the more measures we build up, the more unwieldy this can get. Remember, we want to be really focused here. So then what we need is a system to collect the data. And we can do that through a number of sources. We can use sort of secondary data sources, so things that might live in our data warehouses. We might have access to the clinical commissioning groups, things like that, where they have big data warehouses and things that we can pull that are really important to things that we do. And sometimes we need to think about primary data sources as well. So the things that we may not collect, we might need to create a measurement system. That sounds really difficult, but it's really can be quite simplistic, because remember, we're trying to understand what it is that we're trying to achieve. So we need to set up the right data collection system, just enough data, remember. So we might be collecting it over, a week in the first instance. That gives us a bit of a feeling, it gives us a sense of the status quo. And then we need to also plan accordingly for going ahead, and we'll talk a little bit about what I like to call the logistics of data as we move through. Then we need some way of analysing data. So we need, typically in improvement, we use tools such as run charts. It's almost like a line chart with a median on there. That helps us for prediction, understanding change. It has statistical parameters in there, so we can have some reliability built into that. We can be confident in what the run chart's telling us. And then when we get enough data, we typically use statistical process control, or better known as SPC charts. And they give us a really good understanding of common and special causes. Okay, so I don't want you to worry about that though, because we will talk about that at the end, and often there's software that helps us do that. So you don't have to worry about the statistics. I know someone were a little worried about that. And then we need to review the activity. So we're just looking here, raw performance, what is it that we've done? What have the team done? We work in teams in improvement. What have the team tried out? What does that look like? What does that look like compared to the aim? And then we go in this sort of this circular route then of going back to it. So we've reviewed the activity, we've learned, we've studied it, we go back, we'll carry on collecting the data, we'll keep analysing, we'll keep reviewing. And that's where we're getting into an improvement work. Nice reference, if people are data focused, one of the greatest books that I've probably read, and I have it handy with me a lot, I refer to it now when I'm looking at data, when things get a little bit sticky for me, is the Healthcare Data Guide by Lloyd Provost and Sandra Murray. Really good book for you to maybe access if you've got access to a library. It's an expensive resource, but if your library's got it, great. And just here, just the old Palestinian proverb, you can't fatten a cow just by measuring it. We've got to do something there. We've got, these are the things in improvement. We've got to try things out, make things different. Okay. So this is what we're going to look at: measurement for improvement, or some people call it measurement over time series data. The premise is that we need to be able to understand what it looks like over time. So if we get, this is quite typical as well, and sometimes we see this in like an audit. Okay, so we in this fictitious project, we're going to work on something that's really important. Okay, and when we look at that, we think, well, in June we were just under the 60 mark for those things that are really important. But then look at that in September. Wow, what a difference we've made. we've cracked it, we've solved it. We're on as key performance indicators, we're green when there's something really important. Now, the trouble with this is what we don't have is what's gone on between June and September. So what we need to think about is looking at a little different. If we've popped it over time, we can actually see that we're not getting the full picture here. We're just taking two static points in time. And what we need to think about is, well, what does that picture look like over said period of time? It may be actually something important that there's a linear trend that actually from the January, we've month on month, we've incrementally got that ever so much better at what it is that we're trying to do. So actually we forecast we would be better month on month. Could be a blip. So it might be, you know, blip. When I say a blip, it could be negative, it could be positive. In this situation, we could have just had a one-off month where we've worked really hard, or something's changed just as a one-off. And we'd be saying that we've really improved when really over time we haven't done. We've just been normal apart from a one-off situation. Typical in healthcare, and you'll see this in your data, I'm guessing in your practices, seasonal dips, trends, all these kind of things. These kind of examples is we'd expect to see things. Maybe, I don't know, maybe when we have particular DNAs that pick up in July and August, and largely that's because people go on holiday. Maybe we expect to see that, or particular winter trends, things like when there's flu season, etc. So we've got to be aware of things like seasonal dip. Or finally, it might just be really random. One month to the next, we're scattergun. Sometimes we're good, sometimes we're bad. There's no real consistency with our important activities here, and this is what we see, and that's just what we'll come on to talk about in a few minutes. Is around common cause variation. It's just normal noise in the system, and we don't want to react to them things as well. There we go. So just before, I'm going to just take a little pause for breath for a minute or so, Sarah, just to see if there's any questions. Unfortunately, I'm not the best with tech, so I don't have the chat in front of me, but I'm hoping you do, and you can help me out if folks come through on the chat, or even if people have opted for the Mentimeter. Can I put my teeth back in?
Yeah. There's nothing in chat yet, but I think this really strikes a chord with general practice to me, because I think we've sort of got audit in our veins, and things like the quality and outcome frameworks. You count, then the deadline comes up, and you measure, but you really often just have those 2 points.
Yeah.
I think we're not good at this. We're not good at exploring it, and I really liked what you said earlier about just getting enough data to understand things. I think that's a really good point, and I'm sure many of us on this audience can recognise the don't collect data because it's interesting. You know, we often set off on projects without a really clear idea of what we're doing, and before we know it, we started looking into things because it's interesting.
Yeah, absolutely. And one of the reasons I say that about the interesting versus important is I once did some work with a team, and they wanted to look at around 15 measures. I think it was about 15 measures, and they wanted to look across a locality. So there were a number of areas. And I think at the end of it, I said to the project lead, I said, do you realise if we create that measurement dashboard for you, you're going to have around 144 charts to review? And my question back was, well, what are you going to do with that data? Because for all the will in the world, looking at 144 charts, it's going to be so unmanageable. And that's a bit of an extreme example, but I find it soon racks up. So that's why I think focus really on your There's three types of measures I just want to reference as well, and you might be familiar. What we want to look at is outcome, process, and balance measures. Okay, so outcome measures are the thing that's probably on your aim statement. What is the key metric there? So let's just think dead simple, a personal example more than anything. So if you want to lose weight, for example, so let's say that I want to lose, I don't know, let's just say 0.5 stone by the summer. The outcome measure is me stepping on them weighing scales on either a weekly basis or a monthly basis and understanding what my weight is. That's the outcome measure. But then we might have some process measures. And the outcome measure, just to backtrack a little, sometimes can take some time to move. It's a longer term thing. So process measures really help us out because they sometimes get to the understanding of if things are changing a little sooner, often known as the voice of the workings of the system. So let's go back to the weight example. And one of the process measures for me might be how much exercise I do in a week. That might be one process measure. Another process measure might be number of calories coming in. And another process measure might be calories going out. And if those three things, I think it's fair to assume that if I increase the number of minutes exercise that I do, if I reduce the number of calories coming in and I increase the number of calories going out, it's fair for me to assume that when I jump on them weighing scales, the outcome measure could change. So that's where they're important. And then the final type of measure, balance measure, and that's a thing which is traditionally known as a bit of an unintended consequence. So let's, if we go back to my little example, that might be that actually I've got a gym membership to do them minutes of exercise, but it's really expensive and I can't afford it. I've got to keep one eye on that because it's not sustainable for me. That's a negative. A positive balance measure could be my mood. Could feel great if I'm losing weight, I'm exercising. I might be really, really pleased with how I'm doing. So they were, they're things we just need to keep a little eye on, is the types of measures when we're formulating what's important to measure. So start to try and stratify some of your measures if you can. But the key thing, if you're starting out, just lock ons on the outcome measure. What's the thing I'm really interested in changing here? Okay. So I'm gonna, I'll go ahead.
We've just got a question in the chat there about the difference between audit and a quality improvement project, and a little bit about, do you need data in both and how do you decide sample number? And I think if we think about that as being, audit is often, and you'll correct me on this, Stuart, or add to this, often is audit is often, I need to put my teeth in, where we are using the data from our practice to benchmark against a standard. So it will often be that you'll get assurance data. So something from the outside will say, comparing to other practices prescribe less opiates than you do. You're an outlier. So you'll get something like that makes you go, oh my goodness, we need to do something about this. And so it's common that you would then do an audit. So you'd say, okay, and you have your measures in an audit, you set a very clear criterion and standard. So, and you measure the number of patients that you have that are on opiates above 120 milligrams or whatever, and then you phone them all up. That's it, you're not getting it anymore, and or you organise them to have a review with the pharmacist, whatever you're going to do as your big change, and then you measure it all again. That's very common in audit. To do the same thing, the same project with model for improvement would be a bit like Stuart's describing there about losing weight. You might say, okay, why are we a high rate of opiate users in this practice? Let's have a look, shall we? Let's see. Let's take 5 patients and let's see. Get enough measures, enough data to try and understand why we're over the national average with this. And okay, well, we cover a prison population, or we have these particular areas, or actually we have a lot of terminally ill patients that we look at. So you would use the data that you've got to inform actually what are we going to do, and you would design interventions based on very small numbers of patients, to very, very small numbers, to try and make small iterative changes. Does that cover, do you think, Stuart?
Yeah, it's perfect. It's a perfect explanation. It really, I think you're right, is in terms of the audit. What that's trying to achieve is where we're at status quo. Maybe that's not always desirable, but then actually we need to do a little bit of work and change that. And that goes back into that sustainability element. Is we've kind of cracked it, job done. We've got the point in time, we can use it. Useful audit data is useful. Don't want anybody to think that it's not.
Yeah.
But if we're doing some improvement work, then it's more about what does it look like over time. What's the quality metric we're trying to change for the better for the patient? How do we sustain it? How do we achieve it? So I think you more or less give a textbook answer, Sarah. So you've helped me out there.
We really don't.
Great question, for sure.
We're not good at those other.
Okay, I'm just getting this little feedback on the recording. I'll press on. So, in terms of he's almost, it just needs to be aware. I alluded earlier the logistics. So does the data exist? Is it available? How available is it? Who do we get that from? Who's going to manage it going forward? What does that look like? Do those people have time? Do we have time to collect it? Do the people have time to produce it, analyse it? They need to think about that. And the resources is really important. That's the thing that I think a lot of people's kind of is on people's minds. Who's going to do this? And that's why we need to think about making it manageable. So some people might think when we're talking about making improvements for data, we've got to show all this grand data. We plug the data source in and we've got to show all these changes. Well, actually, it can be really simple to begin with. We could use tally charts, really simple ways of understanding in change. That might be quite helpful to look at as well. And what's the expected rate of the change as well? We've got to think about that. Is, are we realistic with things? Are we, so we need to think about the logistical side of it. I would always encourage improvement teams to involve lots of people. So don't be a lone wolf, because if you do that, what happens when you go on leave? Well, the project falls over. Could we get the receptionist involved? Could we get some of the care assistants involved? Have we got any could we get pharmacists involved? All these kind of people builds up a little bit of a team, and people are willing to get involved. If you set the scene right and give them the purpose, give them the why this needs to change, and build that compelling case for change, people want to come along with it and they want to be part of it. So you can maybe draw on some of their expertise as well, and that might be quite a good thing to do. I'm just going to just mindful of time, and I want to be able to leave you with a few minutes to ask some questions of the overall presentation, anything that I may have missed this evening. I want to think about variation now. It's quite important. So there's two different types of variation that we see is common cause variation. And then the second thing, what we see is special cause variation. These are signals in our data which are unusual statistically often, that signal that something has changed within the process or the system. So when we think about common cause variation, that typically is things that are inherent within our systems. It's normal noise. You remember the little chart where we're bobbing around that I showed earlier. Don't be fooled into reacting to high and low points. There's always got to be them in our data. It's just when they're completely unusual. So I think this graphic shows it quite nice. I'm going to have a little go at it now very, very quickly. Little exercise that kind of shows you special and common cause. But in this image I've put on just depicts, you know, the giraffes are different sizes. It's just normal. Not everybody's the same height. We don't all have our evening meal at the same time. There's variation in things, and we kind of got to understand that and be comfortable with that as well. It's just when it's radically different. So what I'm going to ask you to do very quickly now is, if you've got a piece of paper in front of you, that's a good thing, and a pen, just very quickly, you know, in this process that I've got, World of A's, I want you to write 7 letter A's. Okay, just write them down. And well, maybe I'll do this for yourself here, Sarah. Are they all exactly the same? Every single one, last one of them, are they all perfectly the same?
Nope, absolutely not.
Absolutely not. And so what we're seeing here in the process of writing these letters is it's common cause variation. It's just common, it's normal. Not every single letter is the same. That's important to know. Bringing this into some context here, we wouldn't expect the same number of patients arriving at our practice every day, would we? We wouldn't expect the same numbers of patients coming into the clinic. There'll always be give or take. For example, it doesn't take us exactly the same hour, minute, and second to get to work. It'll always be a little bit different if we're driving into the practice or walking the practice, whatever. That's common cause, okay? I want you to just write one more letter A, but this time I want you to do it with your non-dominant hand, and I want you to write that on there. So just you've got your 7 common cause A's, non-dominant hand here, and just write one final A for me. And Sarah, does it look a little like that?
Yeah, remarkably similar.
Remarkably different, exactly. So what we're experiencing in this situation is special cause variation. It's different. Something's changed that's different. In this situation, I've asked you to change your writing hand. And that's what the difference is. We've put some special cause into the process of writing A's, and we've got something different, okay? So as an example of this, just to go back to our little example that we had before, so perhaps in the COVID-19 pandemic, particularly at the beginning, wave 1, we might have seen that appointments at the practice had dramatically dropped. That people no longer wanted to come to healthcare environments because they were scared they might, you know, they might transmit, they might get the virus or something like that, or perhaps weren't geared up for it. It's a special situation. It's not normal. It's not inherent in the system. Something fundamentally has changed to make that happen. Similarly, we might find that we're a couple of hours late for one day, and that's because the car's broken down and we have to walk. It's different, okay? So we need to think about special cause, but then start to think about, well, how do we spot these kind of signals in our data? Lots of different ways and means of looking at data. You'll be familiar with some of these, perhaps, different ways that you can display your data. You know, we talked about tally charts, word clouds, that's qualitative. I'm focusing a lot on quantitative data here. Qualitative is really important as well. We saw an example on the Mentimeter. Bar charts, stacked bar charts. There's all different ways we can visualize it, and ways that we'll see that. But I want to introduce you just to a really good concept for looking at time series data, measurement for improvement, and that's the thing we want to look at. So when we're using these things called statistical process control charts, we want to understand change over time, and we want to understand if there's variation in the project, in the data that we're seeing and in the project. One of the things that where this came from, statistical process control charts, for those that like a bit of history, Dr. Walter Schuhart, predominantly in the US, He worked at the Bell Laboratories, and what he wanted to have is a way of visualizing change over time. At that time, in the early 1920s in the US, a lot of immigration, so English, American, want everybody's mother tongue, and therefore he still needed to find a way that could visually describe the process so that people could all understand the change. That's where these charts come from. So these are the two purposes: to identify common cause. So when a process is in a state of control, what we'd expect, it's predictable, we expect that to happen. And then understand when there's variation in the process, so maybe when there's some special causes in there, for reasons that we will need to investigate. Okay. So this is what it looks like. I'll just give you a very whistle-stop tour. I don't want you to worry too much about all the mechanics behind it. Remember, we're just giving an introduction here. Lots of textbooks, lots of resources. I'll try and name drop a few of them at the end for you that you can go away and have a look at. So this is a control chart, a statistical process control chart. The y-axis, what's heading upwards, that's our measure of interest. So that's the numbers that we're looking at here. And on the x-axis at the bottom here is the time series. So when we're doing improvement, it needs to be in chronological order. We need to have it frequent enough, so weekly or monthly, daily, weekly or monthly. If you're doing a really small test, you might do it hourly, but normally what I see is daily, weekly or monthly. I don't want to see quarterly or yearly because it's not frequent enough. We can't understand the change. Remember the chart I was showing you about the something that's good. We don't understand the picture in between. It's not frequent enough. Okay. Question you might ask me is, well, what if we're doing it by patient? That's okay. We can have patient 1, patient 2, 3, 4, 5, 6, 7, 8, 9, 10, and so on and so forth. The only caveat is it needs to be in chronological order. We're trying to understand the process over time. Okay. The blue line is our data. They're our runs, what we call a run. So the little diamond are indicating the data point on said month. And the line between is just connecting the data series. Okay. Red line in the middle is a mean, and it's a mean average. So that's looking at a mean average. And the reason why we're looking at a mean in a control chart is because we've got enough data there. If we use a run chart, we use a median. And the reason for that is it's a smaller data set. So we don't want the high and low points to significantly skew our data, right? Then we've got these black tracking lines going across, and these are called control limits, lower control limits and upper control limits. And this really shows the range, the expected range of our data. For those that do like statistics, these are called sigma levels. So it's 3 sigma. It's set out very similar to standard deviations. I said those that like statistics. And they're set at 3 in healthcare, just because obviously there's quite a lot of variability in healthcare. Manufacturing processes are quite predictive and quite tight, so you might see there might be two standard deviations, typically 3 in this. But it just shows our range and our spread. So that's the nuts and bolts of it. There are various signals, which we won't get too deep into, but they tell us when a process is in control or out of control. I'll give you some examples when we run through some. Just going to quickly run through this little case study. It should bring us towards the end there, Sarah, so it gives us 5 minutes or so for some questions here. So first thing is we need to collect some baseline. So we've got a medical practice right here. Just for clarity, the data in this situation is made up. I've not taken any real life data. So we want to collect some data. So what we might look at is the weekly number of asthma review appointments, which we've had a no-show for, so a DNA. Okay, and we're looking at this week by week. It's from September last year. And what we're looking at here is we can see on this chart, we've got a nice controlled process. Remember, there's nothing really unusual about this data. First sign is it's between the upper and the lower control limit. That's a good start. There's nothing significant statistically. If they were outside of that, we'd say, oh, that's a bit lower than we'd expect. Why have we got so many DNAs? School holidays. Or we might say, oh, you know, sorry, a bit higher than we'd expect. It's a bit lower. That's maybe something's just a blip, something like that. But we've got a process. And in this situation, we're receiving week on week 39, roughly 39. The average is 39 DNAs to our asthma reviews, okay? And so if I turn around to Sarah and say, well, what would we have expected on the 6th of December? She'd turn around and say, well, probably 39 DNAs is give or take, because that's our common cause, process is in control, and that's how our process system operates, okay? So we want to continue the collection of data. We're going to try some things out as well. So we need to carry on. So we'll have some really cool change ideas, these PDSA cycles that we're going to try and change to get people to come to the practice, to come to their asthma review. And that could look like a number of things, okay? We're trying some stuff out. And as data's looking like this, so immediately we're thinking, oh, the number of DNAs has gone down. That's a good sign. So what we're seeing here is a couple of statistical changes. The first thing we're seeing is the big cluster of data points outside our lower control limits. That's unusual. It gives us a sign to go and do some investigation. But also, there's a cluster of data here, 8 or 9 data points, which is below that red line consecutively, it doesn't cross it. So there's a shift. Statistically, that is unusual. We wouldn't expect that to happen. So what we need to do as a team is go and investigate. We need to find out what's going on and have a look into that. And then we need to react accordingly. So as a team, we sit down with each other and say, actually, yeah, we've tried out some text messages and emails a day before the appointment. We've tried that out, and that's what we think's had the impact. So what we can do is recalculate based off that shift of data. We can recalculate and say, well, we attribute the change to our pre-screening intervention, our text messages and emails, maybe a phone call, whatever the team have done. And actually, this is our new process. This is what we expect to see. So we've taken the decision to change our process, and we've now got 27. So if I said to Sarah, what do you predict will happen on the 24th, the week of the 24th, you'd say to me, well, we'll probably get about 27 no-shows rather than 39. So that's where our improvement has worked. Some of the questions I saw popping up were about qualitative. This is good practice on a chart, is to actually show the change. So it tells the reader that this is where the change has happened. There's been a pre-screen intervention. You're overlaying some of the narrative onto the data. It's a really good practice to get into. And so you might see some charts and you think, oh, why is the writing on it? In this situation, it's a good thing because it's given some description. We're attributing the change. So these are the key things we need to collect baseline. Number one, really important. Number two, carry on collecting when we're doing the tests. So we've got the baseline, the status quo, with no changes, no interventions. This is what our performance looks like as a practice. We'll carry on collecting the data when we're doing the changes. And then finally, we'll look to see if there's any specifics, and then we'll react to it accordingly and say, maybe this intervention's had a really good impact. We need to keep it, implement it, and then we'll readjust our system accordingly. Okay, so final words on it, and this had, it really is not as complex as, you can make it as complex as you want, basically. If you're like me and you like to get into some of the background of it and understand the calculations, the mathematics, the formulas, go ahead, knock yourself out, you can do that. But what I will tell you is there's straightforward software, free software out there that'll do it for you. Go familiarise yourself with NHS England and NHS Improvements, plot the dots. That's all about looking at data over time. Really good resource. They give you some free tools in there as well. So try that out. If there's anything else on top of that, I'd be more than happy to try and signpost you. There's different types of control charts, but very simply, the one that the plot the dots uses is the eye chart, the averages chart. it's like the Swiss Army knife of control charts. If in doubt, use one of them. The only difference is the sensitivity, but it'll do the job that you need. So really make sure that you do some interrogation data in your collection. Like I said, high level overview of that. Just very finally, Sarah, you might want to, if there's any questions or you've got any that you just want to ask me, but we've looked at the differences of assurance and improvement. We've talked a little bit about audit there. Sarah gave you a really good definition of the difference. I agree with that. How we do an improvement approach: collect data, small amounts, very focused metrics, things that are important, not just interesting. Really focus it up. Don't make it too difficult. If we're going to do something tomorrow morning, what can we do on one day? What can we do, maybe with one patient? Tally charts, things like that. Make it manageable as you get going on this. The better you get at improvement work, the more sophisticated you come with that, the more you can dig into more sophisticated tools as well. Looked at common and special cause variation, so I'll give you some ideas on what you look at there. And then I've just introduced you to the statistical process control chart. And I think other than that, obviously there's some resources, I think, for the overall webinars here, Sarah, but should I drop the slides now? And if there's any questions or anything, I'll just leave this slide up.
I think if you leave that slide up, because that's been a great overview, actually. And I think that, I suppose one of my questions is, and I'll use an example that's in the chat here. Someone wants to do a project looking at the diagnosis of hypertension. Yeah. So that in itself is a difficult one, because it will. We're already starting to think about what do we measure, because they've then gone on to say to reduce the number of missed diagnoses. So that's that's their idea for their project, and I think this is where we would have to somehow go through all blood pressures in a day and see which ones were not acted on that were above a certain threshold, or have some way of our data systems extracting that for us. And then how many days or weeks would you recommend you'd have to do that before you started changing? Because as GPs, we rush, we go, I know what we'll do, and we rush into those change ideas.
Yeah. So I guess what I'd say in response to both, the first thing is, do we have to go and get it all? Can we take a recent selection, just enough to understand, give us a bit of an understanding of it? And then in terms of I think what you're describing to me is the baseline. So what constitutes as a reasonable baseline? Often I would say you could do that in it could be 8 days, because that'll give you 8 data points on a run chart. For anything to be really meaningful, you need at least 6 data points, but we can start that data collection. That could be 8 hours. Remember, if you're doing some hourly, you could get some baseline over an hour and say, well, this is our system performance. Maybe not in the example you gave me, but 8 days, 8 patients. I mean, if you're doing it patient by patient and occurrence, you could do that. That would be okay to do as well. So, but yeah, baseline is really important, because I do see a lot that people just get so enthusiastic about improvement and changes, they'll go off and do it all, and then you ask the question, and well, what were it like before? Like, not sure. We haven't got any data. Does that help?
That's really helpful, and I think those sorts of projects are really important, because it's about what we're not doing, and it's much easier to measure what we are doing. So it's about trying to get that. If we looked at where the blood pressure is actioned on that day, is probably it's an easier one. There's another question coming. I'm aware of time, but if it's okay, I'm just going to ask you this one as well, because it's an interesting one that we didn't come up with when we were planning this. And it's about, what if your baseline data is always going to be 0 because you're starting something new? So how do you show an improvement? And it's not just that you're showing that somebody's using something. So if it's going to be
so that's an interesting one. I guess the baseline is the baseline. So if the position is we don't do something, we can only go from that said point. I think the advice that I would give this person is that as long as you're really transparent about what it is that you're doing, so you're being clear that actually we recognise there's a gap, we don't do a particular process, or we don't particularly do something that we maybe should do, I don't know, but we're starting from this point. What my recommendation maybe is to almost collect some baseline from the new thing. So if you're putting in a change, try the change out and collect a little bit of baseline, because then you can start to bring the continuous improvement work and say, well, okay, well, we've put this new process in, this is what we're seeing, and then as a team, can we do better? Is 50% enough? Can we strive to get 80%? And if so, how do we do that? What are the things we need to consider? And then when you've got your measuring and monitoring system to provide a bit of reliability, I think.
Yeah, I think that's, and also the other things you talked about, the process measures or the balancing measures. Yeah. If we're starting something new, if it's a lot of trainees will do projects about developing a resource or a something that's going to be used in the practice that's new. So we see a lot of sort of signposting guides or tools, and you think that it's always very useful, keeping up to date and all those things. But the balancing measures might be really useful there. Of actually, was it used by who? How did they like it? What was the satisfaction like? What, those sorts of things can be very, very useful to inform other projects. But your baseline would be, no, then you test it out on a few people. What did they think of it? And you might not get to really use it and to really get improvement data on it until it's been utilised for 2 or 3 months. So I think it's useful to think.
Exactly, and it's a bit like a service transformation or redesign. You might have to actually design a process, put a process in place, run it through, and then understand where you can make changes. But really agree with the comments about getting the feedback too. So the verbal stuff, the written down stuff, patients and case studies, things like this, really important to bring the two together is really powerful. And I know I've focused a lot on quantitative data, so if anybody wants to ask me about qualitative stuff, I think my details are shared them, so you can get in touch. I'm mindful of the time.
Well, I could talk to you all night, to be honest, and even though I'd seen these slides, I've still learned loads tonight, and I've been writing wee notes to myself about bits and pieces. So I'm just going to say thank you very much, and this recording of this will be available, and I really hope to speak to you again very soon.
Thank you very much.
Thank you very much, and good night.
Yeah.